Hi, everybody. I appreciate you taking the time to join us this evening for a presentation on kidney stones. If you have any questions, there's a place you can put them in the chat, and hopefully we can get to as many as possible. My name is Alex Tapper. I am a urologist here. Went to the University of Michigan to do my undergrad, go blue, and then did my medical training at Wayne State, and then my urologic surgery training at Beaumont Royal Oak. I specialize in minimally invasive kidney stone surgery, urologic cancer, robotic and laparoscopic surgery, and have offices in Clarkston, Pontiac, and Rochester Hills as well. So kidney stones. Kidneys are two bean-shaped organs. They help filter the blood and get rid of the waste and extra water. And that's how urine is made. The stones form when there's supersaturation or composites of minerals that get excreted by the kidneys and find each other and can either deposit and stay into the kidney or can pass into the ureter and cause obstruction, which is typically when folks have pain. Additionally, there can be sources of infection as well. So as you can see, you have a left and right kidney here. The red part is what we call the parenchyma. And then you have this drainage system where you see the stones now, and you can see there's some non-obstructing stones. And then lower down, there's a stone that appears to be caught in what we would call the proximal ureter, or the top of the tube that drains the kidney down into the bladder. And, as you can see in the picture, there are stones that, range from 2 millimeters to ones that can go over, 3-4 centimeters. As far as types of stones, there are several different types of stones. Calcium oxalate's the most common. It's about 75%. That occurs when calcium binds with oxalate in the urine, commonly due to inadequate calcium or most commonly dehydration that can lead to their formation. Uric acid stones, another second most common type of stone, relates to high purine intake, which has to do with ingestion of like animal proteins and things like that. Foods like organ meats, shellfish have really high concentrations of purines. There are struvite stones, which are less common. They tend to be related to infections in the urinary tract. And then there are cystine stones, which are very hard stones. They're rare and they tend to run in families. Kidney stones are becoming more and more common. Roughly 1 in 10 people can develop stones, 11% of men, 9% of women. Things that can increase your risk factor for kidney stones: family history does play a role. White or Caucasian race, not drinking enough fluids is definitely the biggest risk factor you can have. As we mentioned earlier, meat and other protein-rich foods, diet plays a big role in stone formation. Foods that are high in sodium or sugar, excess vitamin C, believe it or not, can lead to stones. The excess vitamin C in the body will get converted to oxalates, which is the other big component of the most common type of stone, calcium oxalate stones. Folks who have had stomach or intestine surgery, like gastric bypass, become at increased risk for forming stones. They get something called fat malabsorption, where the calcium and the fat bind in the gut, and then you have more oxalate, which is able to get into the urine and bind with calcium there. There are diuretics and calcium-based antacids. Anti-seizure medications can play a role. And then there are other comorbidities that increase your risk of stone, like high blood pressure, diabetes, and obesity. So common symptoms of kidney stones, it's variable for sure. I think the most common one that people relate to kidney stones that are obstructing is pain. Typically we have a lot of people that say it's worse than childbirth. I wouldn't know personally, but certainly pain is a very common presenting symptom. It can be in the flank. It can radiate down to the groin. It can come and go. It has to do with when the stone is obstructing. Certainly blood in the urine, nausea, vomiting. As a stone gets further down in the urinary tract, it can create some what we call storage related complaints. So that it's like frequency, urgency, nighttime urination, things like that. You certainly can see fever with stones. That's more of an emergent finding. So if you have a stone and you have a fever you have a stone that's obstructing in a fever, that's when for sure you need to seek some help. Uh, you know, there are stones that are asymptomatic. It doesn't always has to do with the size of the stone. It's more about location and anatomy. Typically, the reason for pain has to do with the obstruction, and certainly stones that are non-obstructing, even if they're in the ureter and allowing urine to pass, may not create pain. So what can you do to prevent stones from happening? Number 1, 2, and 3 is drinking plenty of fluids. The type of fluids you drink makes a big difference. We typically tell people who are stone formers that, you want to make at least 2 liters of urine, sometimes 2.5 liters of urine a day. Honestly, most people don't measure their urine. So I think a really simple way to evaluate this is to look at the color. If it's dark yellow, concentrated, clearly you're behind on your fluids. And, if it's clear or light straw colored, that's usually an indication of at least, somewhat adequate hydration. Water, coffee, lemonade. Coffee is kind of a mixed bag, depending on whether you're a recurrent stone former or it was a one-time thing. There's data that either supports or sort of refutes that it's beneficial. Grapefruit juice, soda. In soda, there's phosphoric acid, which can change your risk of stones, increase your risk of stones. That being said, if something like a lemon lime soda that's diet may not have as much of a risk. Kidney stones tend to be more prevalent in the summer. That, of course, has to do with dehydration and again, relates back to inadequate fluid intake. So foods make a big difference in risk of stone formation. There's a risk of stones with high oxalate foods, and most of these foods are what most of your other doctors will tell you to eat: spinach, kale, berries, leafy greens, nuts, wheat bran, beets, tea, rhubarb, dark chocolate, dark beer. So it really is found in a lot of stones, and a lot of foods, and it's really about moderation. I always really tell people, you don't want to look at it as this like radical change in your diet, but trying to limit or at least be cognizant about how much oxalate you're taking in and things like that. um, uh, you know it's a an easy way to prevent it. um, as far as dietary calcium goes, you actually want to have enough calcium in your diet. A lot of people think that calcium is the enemy because it's a part of the stone, but realistically, if you don't have enough calcium in your diet, there's a paradoxical effect where it'll increase your calcium in the urine and then increases the ability of oxalates to absorb. So usually about 1,200 milligrams of calcium a day is a good number to shoot for in recurrent stone formers. And then the extra calcium supplements, it's better if you can get it through diet, because some of the times the supplements, the way the calcium gets absorbed is actually more harmful than good. Same thing with protein. Moderation is key. As we talked about before, there's risks with excessive protein intake. It gets broken down to purines, which can increase your risk of stones. High salt intake. Calcium follows sodium into the urine, and so with higher salt intake, you tend to see more calcium in the urine. And again, as we mentioned before, vitamin C in excess can increase your risk of stone formation because it's converted to oxalate. So there's a lot of different ways to treat kidney stones. The first way we try and treat them is with medical expulsion therapy. Depending on the size, location of the stone, sometimes people's history can really determine the percentage chance you have of passing a stone. Certainly the biggest thing you can do is make sure that you're drinking plenty of fluids. Staying well hydrated is very important when passing a stone. A lot of times you'll be given something like Flomax or an alpha blocker, which is to help open the tube. It relaxes what's called smooth muscle in the urinary tract. Hopefully helps aid the stone. The data is sort of mixed, but really it's a pretty low risk, high reward move. In folks that, so this is going back to, I guess, what we call medical expulsion therapy. So that's where we're trying to give you medicine to help treat the stone. It is true there are certain stones that can be dissolved with medication. Uric acid is one of them. Unfortunately, the most common type of stone, calcium oxalate, is not one that can be dissolved, but there are medications that can help prevent stone growth or propagation. So, one of the most common treatments for stones is something called ureteroscopy. That's where we go up with a small scope through the bladder into the ureter and, use tiny tools to either just grab the stone and pull it out if we're able, or more commonly, usually we have to laser larger stones. This is all done under direct visualization. And then typically what we do afterwards is use the basket to pull out, all the stone fragments. Oftentimes we have to leave a stent afterwards. Believe me, if we didn't, we'd rather not leave one also. But what the stent does is it allows protection for the ureter. When you're driving in a structure this small and this sensitive, there's a risk that it swells up and can create obstruction, similar to the experience of having a kidney stone, let alone all the dust fragments that are passing. It allows those to sort of settle and the healing process to continue. As far as how long a stent is left in, there's new evidence now that would suggest that leaving a stent for at least 5 days is beneficial, helps prevent recurrent ER visits. Sometimes stents need to be left in a little bit longer. If, God forbid, there was an injury to the ureter, that might be a time where we leave a stent a little bit longer. Sort of a necessary evil when it comes to stones. Another type of treatment is what people commonly can refer to as lithotripsy. It's really called extracorporeal shockwave lithotripsy. It's where you're using sound waves to break up the stone. Typically during the procedure, we're using flat plate X-ray or ultrasound to identify and monitor the stone. Shock waves are then applied outside the body to help break the stone up. And then, those stones then have to pass. So there are cases where, the fragments get stuck or something like that. But most commonly, people do well and are able to pass the stone fragments. For larger stones, we use a treatment called percutaneous nephrolithotomy, or PCNL. That's a procedure where the stones are removed through a small incision in the back. We then put in what's called a sheath, which is like a plastic tube that allows us to go in and out of the kidney. And then I always tell folks we're using a jackhammer with suction on it. It allows us to treat large volumes of stone quickly, and we're able to suction out those pieces. Most commonly, it's a general anesthetic. In fact, every time it's a general anesthetic. I would say, it's surgeon dependent in terms of like spending the evening and what the recovery looks like, but it does allow us to treat larger volumes of stone quicker. I think we have a brief video here looking at that procedure.
A percutaneous nephrolithotomy is a surgical procedure. The surgeon makes a small incision, about the size of a dime, in your back and inserts a tube directly into your kidney. This allows us to break up and remove the stones. This procedure requires an overnight observation, and most patients will go home the next day. For this procedure, you will have general anesthesia, which means you will be asleep during the surgery. If you are on blood thinners, you must be able to stop taking them before this procedure. This procedure usually requires a stent. A stent is a soft, hollow tube about 10 to 12 inches long and made of a flexible plastic material. The stent is placed in the ureter to hold it open. The stent is usually removed within 1 week after the nephrolithotomy during a brief in-office procedure. For many patients, a stent can cause irritation of the bladder and ureter, which can cause these symptoms: cramping, discomfort and back pain when you urinate, blood in the urine, frequent urination, urinary urgency, and bladder pain. These symptoms can be managed with medication. The benefit of percutaneous nephrolithotomy is it has the highest success rate for kidney stone removal and can clear most kidney stones with one procedure. These are the risks of percutaneous nephrolithotomy. There are higher risks with a percutaneous nephrolithotomy than with any other procedures. There is a 1 in 100 or 1% risk of serious bleeding, for which you would need a blood transfusion. There is a 1 in 100 or 1% risk of fluid buildup around the lungs. If that happens, we would need to insert a needle or tube to drain the fluid. And there is a small risk of sepsis, which is a serious infection. You can usually return to your normal.
All right. The next slide is talking about there's a newer technology that we're using, and certainly it's just a really nice new tool in the toolbox. It doesn't necessarily replace a lot of what we're doing, but offers an alternative and certainly exciting future for stone treatment. So this is called CVAC or CVAC. What it is it's a ureteroscope. So when we were discussing ureteroscopy earlier, this is a type of ureteroscopy, and it's used to not only break up the stone, but it has a suction and irrigation apparatus within the scope itself, and allows us to, again, treat larger volumes of stone with hopefully a better stone-free rate. And that includes getting rid of the dust and fragments that are left. Similar to the ureteroscopy, it's outpatient. I don't know, usually 1 hour or less. It depends on the stone size and location and people's anatomy. So, I hesitate to put timelines on surgery, but, certainly it's a good outpatient procedure and has a role in urology moving forward. So this is what the system looks like. This little box comes with the scope, and the scope is this white piece, and it's steerable and has a suction irrigation device on it. Like I said, there's a channel for the laser fiber to go through, as well as a basket if need be. So the benefits of this CVAC system: it allows not only direct visualization, but it's a very nice picture with a digital ureteroscope. The scope itself has good deflection because there's portions of the kidney that can be challenging to reach. It's compatible with most of the laser fibers we use. It's effective, it's efficient, like I said, I think that there's certainly a role for it. I think the technology is exciting. I'm not sure that I'd tell everybody that it's replacing everything we're doing, but it certainly is a nice new tool to have in our armamentarium. So this is a detailed picture of how the system works. During lithotripsy is where we're using the laser to break up the stone. There's this continuous flow of water throughout that portion of the procedure, allows the dust to clear away from the laser. When it discusses, like, or mentions a snow globe effect, you have to picture that in the kidney, you're in this very confined, finite space. And so if you're breaking up a large stone and you create a lot of dust, it's like working in a snow globe or a blizzard. And then afterwards, you have this active aspiration where the scope is able to suction the small pieces up and, again, allow for not only better visualization, but hopefully better long-term stone-free rates. And here is a short video on CVAC. All right. So I think that pretty much wraps up what I had to say about stones. I'd be happy to take some time to answer questions. I hope it was informative and helpful for everybody who joined. I appreciate you taking the time out of your busy schedules to um, talk with me. So, why don't we start answering some of these questions here? Um, So the first question was, can a non-obstructing stone go from non-obstructing to obstructing and back and forth? It's an excellent question. Yes is the answer. A lot of times we'll see larger stones up in the kidney, ones that are greater than a centimeter, that can do something called ball valving, where essentially they'll pop into the ureter and then pop back out because it's too large to move forward. Additionally, part of the reason when folks are passing stones that they have intermittent pain has to do more with the obstruction. So, in other words, when the kidney's obstructed and swells, that's where you can have pain. And then if the stone shifts in such a way that urine's unable to pass and that swelling resolves, that's where you get resolution or improvement of the pain. Um, can you take anything to dissolve kidney stones, pills or drinks? Yeah, it depends on the type of stone. So uric acid stones commonly can be dissolved. Cysteine stones can be dissolved. Again, those are rarer and more familial than anything else. Uric acid stones, you can acidify the urine, alkalinize the urine, which helps dissolve stones. Like I said, with calcium oxalate stones, really the goal is more about preventing uh, further stone growth or new stone development than it is about being able to actually dissolve the stones, chemically. As far as drinks go, oftentimes we recommend, lemon juice or Crystal Light, sugar-free Crystal Light, something that has some acidity to it. I know there's folks that use apple cider vinegar. What that does, it has a paradoxical effect on the acidity of the urine and can help, again, prevent that the calcium and oxalate molecules from finding each other in the case of calcium and oxalate stones. Um, Someone asked about, currently passing a stone and have a scheduled follow-up ultrasound. And aside from waiting it out, is there anything else that can be done? The biggest thing is pushing fluids. Like I said, there are medications that can be prescribed by your urologist, or oftentimes your primary care doctor can do it as well. The most common one we use is called Flomax or tamsulosin. There's mixed evidence on the efficacy of it. It depends on where the stone is, how big it is, but again, um, uh, very little risk and relative to the reward if it's effective. Certainly, if you start having fevers, chills, nausea, vomiting, where you're not able to go and keep fluids down, then frankly the stone won't pass anyway, and so it's really helpful in those cases to just either call your urologist or unfortunately sometimes you just got to go to the ER for pain control and fluids, and in the case of a fever it turns into a more urgent or emergent surgery. Someone's asking about a young patient, 21, passing their third stone, and what recommendations would be. Typically in any recurrent stone former, we recommend what's called a metabolic eval. That has to do with collecting your urine for 24 hours on two separate occasions, and then we correlate it with some blood work. It helps determine what's in the urine, what's the risk factor for stone formation. Oftentimes, no question, the most common finding is that people don't drink as much as they think they do. I'm as guilty as anybody. And that's really a helpful thing to do to help prevent stones. In folks who are recurrent stone formers, there are medications we can give to help prevent future stones from forming, even if they do have a risk of calcium oxalate stones. There's other metabolic issues that can predispose to stones. I saw a question on here about hyperparathyroidism, which certainly is a risk for stones. The question had to do with why it wasn't addressed more often. I can tell you that on our, metabolic workup, the parathyroid hormone is one of the things that gets checked reflexively. I can't speak for other places, but certainly that's something that we try to keep in our back of our mind. Nobody's perfect by any means, but try and do our best to being thoughtful about the etiology as we possibly can. Why avoid grapefruit juice? That's a good question. There's actually mixed evidence on grapefruit juice. There's some evidence that it can increase the oxalates in the urine, and then there's other evidence that it doesn't really change anything. Like I had mentioned before, we commonly reference lemon juice or sugar-free lemonade, things like that. Those are fluids that we know will help change the acidity of the urine in a beneficial way. Orange juice is a little bit of a mixed bag because of the vitamin C, which, in excess can increase your risk of stone formation. Got one here that says, why do calcium antacids help create stone formation? A couple of things. So when you have dietary calcium, the benefit of dietary calcium is that there's portions of the diet that involve oxalates. So let's say someone's having like a spinach salad or beets or something like that. If you then are having cheese or some calcium source on the salad, what happens is the calcium and the oxalate bind in the gut and don't allow the oxalate to get in the urine. If you're taking calcium separately, just let's say a morning vitamin or something like that, that's where it's not being combined with the oxalates, and then the calcium is free to get absorbed and changes the dynamics of the mineral absorption in the body. The next question says, if an ultrasound shows a 3 or 4 millimeter stone, can it be addressed or blasted before it starts moving and causing pain? Another great question. So ultrasound certainly is the most common tool we use in terms of monitoring stones. There's no radiation. It's cheap. It's quick. It's easy. There are limitations, though. It is not the most exact imaging technology that we have. And certainly there's risks of both false positives and false negatives. So, on ultrasound, we tend to see an overestimation, particularly of smaller stones in terms of the size. Based on stone size is really where we decide, what the benefit of is or would be of treating the stone or putting you through the risks that come along with treatment. And albeit it's a minor procedure, but hey, every surgery has risks, and certainly understanding the risks and knowing, what it could entail is important. Usually for a 3 or 4 millimeter stone, we tend to favor a more conservative approach. There are populations like pilots, for example, can't have non-obstructing stones in their kidney, but typically if a stone is 5 millimeters or less, your chance of passing it is high enough that we don't reflexively go after them. As the stones get larger and the percentage chance of spontaneous passage goes down, that's where sometimes we will talk about, sort of a prophylactic treatment. Certainly, the cases can be tailored to, each person's, wishes and understandings of, again, the risks and the benefits. Stones found in the kidney, not in the urine, or how big is too big? Good question. So, what we say is basically, statistically speaking, once a stone reaches a centimeter, 10 millimeters, it's too big to pass. There's exceptions to the rule. I've had patients pass stones that are larger than a centimeter, but it's rare and it's uncommon and certainly not the norm. Once a stone starts to get over 2 centimeters, that's where there's actually morbidity to having the stone up in your kidney. They can be risk for infection. They can cause long-term damage to the kidney. And so that's where a lot of times that percutaneous nephrolithotomy is used. Some of these newer technologies between newer lasers, as well as that CVAC technology that we touched on, can be used too, and depending on the case. If you have a lithotripsy procedure, is it really necessary to have a stent in for longer than 2 or 3 days? Yeah, the data would suggest that a stent that's taken out before 5 days can increase your risk of going to the ER. I think it's person dependent. I certainly have had patients where I take it out sooner. I think everybody's preference, like I said, ourselves included, would be to not leave a stent, but sometimes it's the safer approach, and you'd rather go through one surgery that's done properly than end up back in the ER with issues. And even in the best of hands, the most perfect of hands, there's always things that can arise, and so you try and take the most calculated approach you can. So they're frustrating for both parties, certainly patients more than us, but it's I would say typically, leaving it in for at least 5 days is a good idea if there's going to be a stent left in. There's a stone about, excuse me, a question about how long stone should stay in the kidney without damage occurring. Again, it depends on the size of the stone. Certainly, you could have a 4 millimeter stone that sits in your kidneys for the rest of your life and never causes a problem. We typically monitor because we want to make sure they're not getting larger because, as I touched on, basically, as the stone gets larger, your chance of spontaneously passing it goes down. And then if a stone gets to be, very large, and there is some risk with having it in your kidney, but those are stones that are, multiple centimeters. Animal protein is what there's a question that asks about limiting protein. Is it animal protein, plant protein, both? Tends to be animal protein. That's the one that increases your risk of stone formation more dramatically. Someone asked a really good question about what type of professional is best to consult with learning to balance diet, blood pressure issues, things like that. There's really a team approach. I think a dietitian or nutritionist is never a bad idea. We work very closely with our nephrology colleagues, so we kind of think of ourselves as plumbers. The nephrologists are who work on the cellular aspects and more of like the molecular understanding of the kidney. In other words, they're very beneficial in terms of like controlling blood pressure and your overall kidney function when it's not related to obstruction or anything like that. So it's a team approach, but I definitely think that a dietitian or nutritionist, there's no harm in talking to somebody like that. Let's see, how is a stent removed? Great question. So the stent is removed one of two ways, three ways, I guess I'll say. One is sometimes we leave the stent on a string. So what that is you have a little string that's coming out of the urethra. In men, the string is typically taped with a small sticker to the top of the penis. In women, either to the inner thigh or to the what's called the mons pubis, or like just above or on the pubic bone. And then it gets removed by pulling the string. The stent flies out. And it can be done by yourself at home, or oftentimes we'll have people come in and just have a nurse or medical assistant pull it. Other ways the stent gets removed, if there's not a string left on it, a lot of times we just remove it in the office. We pass a catheter with a small camera on the back of it called a cystoscope, have a little grasper that goes through that scope, which is generally speaking a pretty quick procedure, but certainly passing a catheter can add some level of discomfort. But people tend to tolerate it well, and then there's always folks who want to be under anesthesia. No judgment, there's risks with anesthesia, but you got to do what's best for you, and as long as you understand kind of what comes along with that and the scheduling that comes along with it, sometimes we do it under anesthesia, but it's the same procedure really. Are chills a symptom of kidney stones? It's hard to answer. Sometimes yes, sometimes no. Certainly if you're passing a kidney stone and you have fevers or chills, that's when you need to go to the ER, because what we worry about is when you have an infection and obstructing stone. That's an important thing. CVAC does require a stent a lot of times. Again, it has to do more with like healing than the procedure itself. Yeah, it's provider dependent and case dependent and stone dependent. So it's painting a broad brushstroke on a question that really has a lot of detail to it. But generally, CVAC certainly, involves a stent typically. Removing a 2 to 3 millimeter stone, again, that's where you'd look at, your ureteroscopy and driving up with a scope and a basket. If it doesn't pass, in most cases, you'd look at something like medical expulsion therapy for that. Usually about, if it's 3 millimeters, 85-90% chance it'll pass. Let's see. It's a good question. What determines whether you would use CVAC for a stone? So what determines if you would use CVAC is really the surgeon you're working with, or the urologist you're working with. In my case, larger stones that are up in the kidney, and specifically if someone maybe is not a candidate for a surgery like a PCNL, the percutaneous nephrolithotomy, where we go through the back, yeah, but I think it's person dependent, and certainly I have colleagues who use it a little bit more frequently for smaller stones. And, as long as you're comfortable with the person you're working with, I think you get an honest answer about that. It's a good question. I'm going to be honest. I don't know the answer to it, but I think it's a good question. Any connection with stone formation in people with milk allergy, like a lactose intolerance? I'm not aware of it, but I'd have to look it up. I don't know 100% if there's any new evidence about that. Good question. Have I ever passed a stone personally? No. I hope to never pass a stone, but I try and be empathetic and sympathetic to what all the patients are going through, despite my lack of experience in that specific area. If you have no symptoms, do large stones need to be removed? Yes and no. It depends on the size. So as I said, if it's sitting up in the kidney and it's, greater than 2.5 centimeters, there is morbidity with having those stones up in the kidney. If a stone is in the ureter, typically, it's best to remove it at some point if it's not passing. There can be long-term damage from obstructing stones, even if they're asymptomatic. There's a question about new studies showing bacteria in kidney stones, and is the information going to change treatment? I would say not directly. We always get a urine culture before treatment. And that's what dictates a lot of, sort of the pre or perioperative care when it comes to treating stones. There's certainly stones that we know are highly likely to harbor bacteria. Those stones require a little bit more of a comprehensive approach when it comes to preoperative antibiotics and monitoring. And so, I don't know that that's going to change things dramatically, but certainly it's very important that they get a preoperative urine culture. How do you know what type of stone you have? So when your stone is broken up, we send it for analysis. If you pass your stone and are able to bring it to the office, we can send it for chemical analysis. Again, for most people, you'd kind of just assume it's calcium oxalate, but certainly it never hurts to have a little extra information and know what it's made of. Let's see. Someone asked, they have a 2 millimeter stone that's not bothering them. Is there anything they can do to prevent it from passing? Short answer is no. Unfortunately, stones can pass at any time. There's things you can do to prevent it from growing, and when it drops, you can do things to help allow it to pass. But unfortunately, a stone that's already there, it has a possibility of passing. The stone location matters. Stones that are in the lower pole of the kidney have a little bit harder time passing than, let's say, stones in the renal pelvis, kind of the middle portion of the kidney, or even the upper pole. Someone asked, is through the back surgery painful afterwards? Every surgery has discomfort associated with it, even though we like to bill it as minimally invasive and, outpatient and simple. As I said, I mean, every surgery has risks and benefit, and certainly, there's very rarely a pain-free surgery, as much as we'd love to have that for you. Most people are able to kind of get back to their normal lives a week or two later. Some people are a little slower healers. Some people bounce back in the office and you're like, holy smokes, never had anything done. And so it's a little person dependent. Someone asked if the CVAC system is better for getting lower pole stones out, and are the doctors at MIU, all of them, using it? I would tell you, no, I don't think all of them are using it. I don't know that for sure, but certainly I think, everybody's kind of got different comfort with different tools, and the CVAC is really, it's been out about 2 to 3 years from my knowledge. A CVAC certainly is appropriate for a lower pole stone, but there's, plenty of stones we treat without it that do just as well and have good stone free rates and things like that. Um, Someone's asking about long-term Flomax use for stones. Once the stone is passed, if you're not having any urinary concerns or troubles, particularly like a female patient, Flomax is not a long-term thing. So once your stone passes, you don't need to be on it long-term. Of course, check with your provider about that, but typically speaking, it's not a necessary long-term medication. Oh, it's a good question. So somebody's asking about over-the-counter supplements for stone prevention. Like there's one that's commonly used called Stone Breaker. There's a lot of mixed evidence about these. I would just say buyer beware. I don't claim to know everything, and certainly have a lot of patients that like to use supplements, and I'm all for it. I think kind of a mix of a naturopathic and Western medicine approach is great. As long as you're not doing yourself any harm, I think wonderful. I think you should be sort of the champion of your own care. But you have to be careful. Unfortunately, there's a lot of snake oil out there these days. And so you just have to, know where it's coming from, know what's in it. And certainly I never mind if someone brings something to an appointment so we can just kind of review what's in there. Can't say I know every, root or berry in the world, but, try and be as helpful as I can about it. If you are a stone former, will you have a lifetime of kidney stones? Person dependent. I certainly have people that I've just told them, point blank, yes, this is probably going to be a long-term issue. And despite our best efforts, the goal is really to go from going yearly to every 10 years. But there are some people where the stones are just very challenging to treat and prevent. But we work closely with our nephrology colleagues in those cases, and yeah. Is it common to have trace or scan amount of blood in your urine when you have kidney stones? Yeah, it can be a presenting symptom. It all depends on the person. Certainly, microscopic blood in the urine is very common. What we call gross hematuria, which is where you actually see blood in the urine, is common. Just because the urinalysis is negative doesn't mean that you don't have a stone. But yes, we do commonly see blood in the urine with stones. There's a question here about what facility or hospital I use for my stone removal procedures. I work at Trinity Health Oakland. I work at Corwell Royal Oak, and then we have a surgery center I work out of as well. But fortunately, we're in an area where there's a lot of good places that you can get treated, and a lot of qualified people to treat too. So I know that's not necessarily close to everybody, and certainly our group would be happy to help if you live somewhere else and need someone closer to you. What, if anything, might trigger passing of a stone? Pain would be the most common thing. Certainly we see like blood in the urine also, but pain would be the most common presenting symptom that we see. And a lot of times folks who have had recurrent stones seem to know pretty well when a stone is coming. This is a good question. Someone asked, they have some other comorbidities that make it difficult for them to get to the bathroom. And so they're trying to limit their fluids because of that. And they asked about a minimum amount of fluid we'd recommend. I'd say, typically we want you to drink at least 12 8 fluid ounce glasses of water a day. Again, for recurrent stone formers, we try and get you to make 2.5 liters of urine a day. But, I'm a big moderation person where I think, as long as you're doing, being thoughtful about it, then, it's better than nothing. And so, if your lifestyle or your, situation doesn't allow you to drink that quantity of water, or let's say you're traveling or have work or whatever, some is better than none. And what's in the water makes a difference, or what type of fluids you're drinking makes a difference. And so I think that's, certainly it's about baby steps and doing little things you can to help. Good question. Someone asked about, having a history of stones, no recent imaging. Is it worth having some imaging done to see if there's any recurrent stones? Um, I don't know. I tend to think that an ultrasound's a really simple way to evaluate for stones, and I would tend to be on the side of monitoring. I don't think you necessarily need to have an ultrasound every year, but knowledge is power, and so it always can help to know what you're dealing with, and is it something that needs to be followed or not. Um, let's see. We've got time for a few more questions here. Um, oh, this is a good question. So somebody's asking about the effects of reduced kidney function with long-term stone obstruction. I guess I'm assuming long-term stone obstruction, and the expectation of kidney function returning. So when a stone's been blocking the kidney for 4 to 6 weeks, that's where you can start to see kidney damage. Kidneys are pretty resilient. So when they get unobstructed, there is a chance of return or improvement in renal function. Doesn't always happen, but certainly, again, I don't know the specifics of this situation, but there's hope in a lot of cases that the kidney function will improve. But again, there's some factors that I can't really predict that may portend to less recovery. But oftentimes, just close monitoring, follow-up ultrasounds, things like that can really help. Um, there's a question about if crystals break off in the stones, can they cause pain when passed? Certainly, just because a crystal's 2 millimeters or a little fragment's 2 millimeters doesn't mean it can't obstruct or cause pain. Less likely, but it certainly can. And then there's a question about whether CVAC would work with staghorn stones. It all depends. Again, it depends on the stone size, location. Staghorn stones classically are treated with the PCNL. But certainly kind of these newer technologies with the attached suction device or the better lasers that we're getting offer us good opportunity to treat stones. So I think that's where we'll leave it for the evening. I really, really appreciate everyone taking the time out of their schedules to join me. I hope it was helpful or informative. There is a little screen at the bottom if you'd like to talk more, request an appointment. As I said, we have a lot of providers throughout Southeast Michigan who, I'm sure would be more than happy to help. So thank you very much for your time and patience, and I hope everyone has a great day.